Oh,
And thank you, David, for coming back also. David has written a book called The Great American Healthcare Scam, and he gave a talk on the 26th, was it, about the first, part one we're calling it, and this one is going to be more about insurance and Medicare today, is my understanding. So David, thank you so much for coming.
can everyone hear me?
Yes.
Oh, great, great, great. And can everyone see my slide right there?
We see it.
Okay, great. All right. Okay. So yeah, like you said, tonight is part 2 of The Great American Healthcare Scam, the book that I wrote, How Kickbacks, Collusion, and Propaganda Have Exploded Healthcare Costs in the United States. And much of what I'm presenting to you tonight is backed up by information on my website, truecostofhealthcare.org. And again, a couple of weeks ago, I presented part 1, which was about prescription drugs and medical billing. And tonight is part 2. Let's see if this works. It's not working. Oh, wait. Oh, health insurance. It's money for nothing when the risk is free. All right. So to recap some of the stuff that I said on the last presentation, because it is still important for tonight. On prescription drugs, remember I told you that 87% or 7 out of 8 prescriptions in the US are for generic medication, and most of these medications cost pharmacies only pennies per dose, meaning that contrary to popular belief, most prescription drugs in the United States are not very expensive. However, the insurance copay for most generic prescriptions are usually more than the medication actually costs, meaning that insurance companies, instead of helping people purchase these medications, if anything, tend to get in the way. Also, brand name medications, which are 1 in 8 prescriptions filled in this country, are insanely expensive, often 100 times the price of the generic medication, even for the exact same medication. Part of the reason they're so expensive is that pharmaceutical companies pay large rebates to the pharmacy benefit managers who choose which brand name drugs would be on which insurance plans, and these rebates are what are encouraging the runaway price inflation for these brand name medications. Also, medical billing. I mentioned that and showed repeatedly that medical billing costs, medical billing charges are insanely high, but often meant to be works of fiction, in that most insurance companies pay only a fraction of any medical billing charge on any medical bill most of the time. However, these insurance payments tend to be random, chaotic, have little to do with either the total charge or even the medical services provided on these bills. And insurance companies are using these inflated billing charges to hide the fact that they are purposely driving up medical costs whenever possible. They do this by overpaying in order to increase the revenue by leveraging the medical loss ratio. All right, so that's the recap. Tonight, we will talk about private health insurance, what they're really up to, and Medicare. Okay, to begin with, I'd like to contrast private health insurance with other insurance. Okay, there are a number of ways in which they're fundamentally different. The 3 I'd like to highlight in the beginning are the facts that we tend to use our health insurance for every interaction with the healthcare system, which is very unlike other insurance. I mean, you would never use your car insurance to fill up your gas tank or change your oil or even overhaul your transmission. You don't use your homeowner's insurance to repair a broken window or pay your electric bill. You use your health insurance to buy a bottle of pills that shouldn't cost $3. You use your health insurance to pay for an x-ray that's, you know, maybe $40, or a doctor's office visit that's, you know, $65 or $70. Whereas you would never use other insurances for such trivial expenses. Health insurance also tends to be far more expensive than the other types of insurance we pay for. And we tend to receive health insurance as, at least if you're not on Medicare or Medicaid, you tend to receive your health insurance as an employee benefit if you have it at all, which, you know, most other types of insurance you pay for yourself. Now, just to underscore the price, our health insurance, I get it from my wife. She gets it as an employee benefit. $22,000 a year is what's spent between my wife's employer and herself on our health insurance for a family of 4, which, with no medical conditions. Now contrast this to my medical malpractice insurance. As a practicing physician, I actually pay less than $5,000 a year. And there's this belief out there, another myth, that medical malpractice is insanely expensive and breaking doctors. Well, I'm here to tell you that most orthopedic surgeons in California spend a lot less on medical malpractice than it costs to provide health insurance for a family of 4. So yes, health insurance is far more expensive than what we might pay for auto, homeowners, life insurance, or anything else. All right. And as an employee benefit, what most people are not aware of is the fact that most employers now are self-insuring using what are called administrative service only contracts. They're either abbreviated as ASCs or ASOs. On tonight's discussion and in my book, I use ASCs. So administrative service contracts, where the employer actually covers all of the healthcare costs with their own money rather than the insurance company for all employees. All right, they become increasingly popular over the last couple of decades. As this graph shows, so this is, again, from the largest private insurance companies that offer commercial health insurance. You can see a couple of things on this graph. So this is the total number of privately insured by these companies. And as you can see, that total number has not changed since about 2005. So for about a decade and a half, and in fact, in the United States, the total number of people with private insurance has not changed dramatically in the last 2 decades. Not the percentage, the total number, all right? But more importantly, the blue part of the bar on the bottom is the number of people these insurance companies insure directly, in that they pay for the appendicitis, the doctor's office visit, the healthcare benefits. The insurance company pays for it, whereas the green part of the bar shows the percentage of people, or the number of people, these insurance companies only cover through what are called administrative service contracts, where the person's employer pays for all medical costs. And as you can see, by 2017, 76% of all private health insurance was actually administrative service contracts instead of insurance. And this is a problem for a number of reasons that I'll go over tonight. All right. First, how do these work? So the employer sets up an account that belongs to the employer. All right. It's a bank account that belongs to the employer, and that the money belongs to the employer, but that the insurance company is free to write checks off whenever they need it. The insurance company uses that account that belongs to the employer to pay all medical claims, all right, that happen for the employees, all right, of that company. And then the insurance company is responsible to tell the employer only the total amount paid on all claims each month. So the only feedback the employer gets on what was purchased and how much was spent is the total amount, so that the employer can refurbish the account each and every month. They are not given any specific details most of the time on what medical claims were paid for and how much was paid on each medical claim. All right. So the reason this is a problem, all right, well, first, the apparent advantage to employers. The reason employers are going with these is that on the surface, they appear less expensive. The fees insurance companies tend to charge for administrative service contracts are only about $25 per member per month, which is certainly a lot less than the $300 to $600 per member per month that full insurance would cost. All right. Plus, it gives the employers the illusion of controlling their healthcare costs by supposedly eliminating the middleman. Unfortunately, and it also bases on the assumption that health insurance companies, the belief that health insurance companies will always strive to get the best deal on healthcare costs whenever possible. In other words, if the health insurance company is managing your healthcare expenses, even when it's with your money, they will always strive to get the lowest cost and be as parsimonious as possible. Well, if you paid any attention to my last talk, you should know that's not true. Health insurance companies, if anything, benefit from driving costs up. And now, with these administrative service contracts, they're basically operating on an unlimited expense account for which they're not really accountable to anyone. All right. So the reality is, what these insurance companies have managed to do is put themselves in a position of risk-free risk management. They are managing the risk of employee healthcare benefits, which is what insurance is about. It's about risk management. But they don't assume any of that risk. They have no skin in the game. All right? They've offset all of that to the employers. And what's more, they have almost no accountability to anyone. If the employer wishes to look at the actual claims, which is an incredibly difficult thing for them to do, assuming that they would even understand these claims, were they able to look at it. I mean, I've gone over this with a couple of employers now, trying to audit their claims. But somebody actually sent me an example of an administrative service contract for their company. And here it says, at plan sponsor's expense, in other words, if the employer wishes to audit the accounts, they have to pay for the audit, right? The plan sponsor shall have the right to audit claims on Anthem Blue Cross Life and Health premises. In other words, they have to go there. They aren't sent them. They have to go there, look at them during business hours. And they are not allowed to have a third party with them to help them understand this unless the insurance company has signed off and approved of that person. In other words, looking at the specifics of the claims, how the health insurance company is spending the employer's money, is nearly as difficult as looking at Donald Trump's tax returns. So the insurance company has little, if any, actual accountability to the employer. They're spending the money of the employer basically with impunity and have written themselves completely out of all of the risk. All right. Put another way, instead of employers eliminating the middleman with administrative service contracts, they place the middleman in a position of absolute power with no accountability. All right. I think you can see why that would be a problem. Now, here's a graph I showed on my last presentation. And at the time, I was talking about the medical loss ratio and how private insurance companies are leveraging the medical loss ratio to drive up their costs. This is true. It's undeniable that health insurance companies do benefit from higher costs overall. And as you can see, the purple line is going up much more quickly than the yellow and green lines, which are Medicare and Medicaid, what Medicare and Medicaid spend for, in this case, it's for each hospital inpatient. All right. Private insurance companies, which insure the working well, spend a lot more money each year on hospitalized patients than Medicare and Medicaid, which cover the elderly, the disabled, and the impoverished. You'd think it would be the opposite, but as I said last time, private insurance companies benefit from higher costs. But another thing that's pushing this line up for the private insurance companies much faster is the fact that they really have no accountability for what they're spending. In other words, it doesn't matter to them how much they're spending. They benefit from higher costs. They have, no accountability for this, so they keep sending more and more money to the hospitals. And of course, as I said before, the hospitals aren't complaining. And so you might think, okay, why don't insurance commissioners get involved with this? If this is such a complete ripoff for employers, can insurance commissioners at least look in on it? No. And here's an interesting loophole in the entire issue of employer-sponsored healthcare. Employer-sponsored healthcare in general, since it is a benefit, is not covered by any state insurance commissioner whatsoever. Instead, it is regulated, use the term loosely, by the Employer Retirement Income Security Act of 1974, okay, ERISA. This was passed obviously in the early 70s, as a law that was meant to protect, it was a law that was meant to protect pensions, all right? Basically, the entire focus of the law is to say employers can't liquidate pensions whenever they feel like it, which is a good thing. Unfortunately, ERISA says nothing or next to nothing about insurance at all, certainly not health insurance in particular. However, over the years, federal courts have decided that since this applies to employee benefits, it should be a blanket law that applies to all employee benefits. Since federal law supersedes state laws, there is no state jurisdiction over employer-sponsored benefits. And what's more, since the insurance company never physically possesses any of the money used for administrative service contract expenses, there is no state regulation whatsoever for any employer-sponsored health insurance, certainly not the ASCs. All right. In fact, none of the specific financial transactions that occur within an ASC are reported to anyone. Again, the insurance company never possesses the money, so it never makes it anywhere on their financial statements that they report to the SEC. Put another way, roughly 76% of commercial health insurance are these administrative service contracts, meaning that roughly $800 billion a year spent on healthcare is spent completely in the dark, unregulated, unmonitored, unaccounted for. I hope I don't have to explain to you why that's a problem. It's probably one of the greatest looming crises in healthcare, if not to our economy in general, that absolutely nobody is talking about. All right. And an interesting aside is how this relates to the Affordable Care Act, also known as Obamacare. All right. The insurance companies were livid about the Affordable Care Act, and everyone was like, why? This is giving them more business, and wasn't this a conservative plan? Well, it was a conservative plan in the 90s before the health insurance companies decided they wanted to get out of the commercial health insurance business. And this was the point. First, it did place a few minor federal regulations on all health insurance, which did actually apply to employer-sponsored health insurance. And the insurance companies were happy with the Wild West issue of no regulations whatsoever, since only ERISA covered them. But more specifically, what they disapproved of was the fact that it was attempting to draw the health insurance companies back into the commercial health insurance market. They were trying to get out of it. Remember, commercial health insurance is that blue bar that keeps going down, down, down every year. They're trying to get away from it. And the Obama administration said, hey, we'll pay you some money to, take on all these extra private clients. And they said, we don't want them. All right. Which brings me to the next subject. If private insurance companies don't want commercial insurance, who are they insuring? Medicare and Medicaid recipients. That's the customer base they are looking for. And this is really important. So this graph, remember, the graph before showed you that the total number of people with private insurance companies is barely changing. This is the number of privately insured Medicare and Medicaid recipients each year since about 2003. You can see it's gone up about 7 times over about a decade and a half there, right? The insurance companies are scrambling to sign up as many Medicare and Medicaid patients as they possibly can. And any of you who are on Medicare, I think you already know that, because if you're on it, you were probably harassed endlessly as you were about to go on it by the private insurance companies trying to sign you up. This graph shows the proportion of premium revenue companies that offer both private insurance and Medicare and Medicaid plans are getting from Medicare and Medicaid each year since 2003. You can see only just over 1/5 of their premium revenue came from Medicare and Medicaid recipients in 2003. Now it's almost 2/3 of their revenue. That's the business that they're after. And the four major types of policies.
David?
Yes?
Some people are having trouble seeing your screen, so I just want to take a second to make sure that everybody is able to do that, because it would be hard to read it if they couldn't have it on the big screen. So if you look in your upper right-hand corner, there's a couple of icons that let you choose what your view is. And there should be one labeled the speaker view. And if you click on that, then David's video of his face will be the same size as everybody else's, and his screen should be on the main screen. I can see his slides just fine, but two other people have commented to me that they cannot.
I think I just lost my mouse too. It says something about someone is requesting a remote control of your screen, and it says decline or approve, and I don't have any control of my mouse. What do I push? Can everyone see my screen now?
Okay, I can see your screen, and I can see a few heads nod in the window that I'm in.
Okay.
Can you nod your heads if you can see his screen fine?
Okay.
Okay.
All right. So
Mike,
back.
Are you seeing it, Mike? You're muted.
I still don't have my mouse. So
the owners and co-hosts
is.
probably can't see the screen.
Okay. Okay, so you can go ahead, David. I'm sorry for the interruption. Are you able to?
Oh, here it is.
Who's trying to take control of your?
Someone named Chuck. I don't know. Anyway.
Oh.
So let's go back to the types of private insurance policies they're selling Medicare and Medicaid recipients, because that's going to be most of the rest of tonight's discussion. So you have Medicare supplemental policies, also called Medigap policies, where a private insurance, policy covers your deductibles and co-insurance with Medicare, right? You have Medicare Advantage, where you sign over all of your Medicare benefits to a private insurance company to manage them for you. Part D plan covers prescription drugs for Medicare recipients, and then Medicaid managed care, which is a bit like Medicare Advantage, only for Medicaid patients, where private insurance company manages the benefits of poor people. All right. Okay. Now, you got to wonder, based on what you just saw, what about pre-existing conditions? Medicare covers only the elderly and the disabled. Medicaid covers only the impoverished. Isn't that a whole lot of pre-existing conditions? Why are the health insurance companies lining up to sign up all of these elderly, disabled, and impoverished people if they are so obsessed with never having any pre-existing conditions? Right? I mean, isn't that the largest pool of pre-existing conditions in the country? I mean, if you are about to go on Medicare, about 6 months prior, your phone will start ringing off the hook with insurance agents who want to call you, want to sign you up for any one of these policies. I bet you none of them even mentioned a pre-existing condition. You could be having chest pain while you're on the phone with the insurance agent. They will sign you up, no problem. And yet they won't take a 40-year-old with high blood pressure because it's a pre-existing condition? Really? So in order to understand what it is the insurance companies are up to and what they're trying to do.
Yes.
I'm going to sign off.
We need to discuss Medicare more specifically. What does it cover? How does Medicare cover what it covers? And what, if any, benefit are seniors getting from these extra private health insurance plans? All right. Now, in my book, I make this statement. Seniors with Medicare have about the best deal for their health care anyone can get in the country. Now, that statement in and of itself almost doesn't really say very much, because if you've been paying attention to what I've been saying, the private health insurance companies haven't been offering a very good deal at all. It's a pretty low bar to beat. All right. So I think tonight I need to get a little bit more specific. And I always start with hospitalization. Anytime I meet a senior with Medicare who's wondering about how Medicare covers anything, I ask them this question. If you have Medicare and only Medicare, and are hospitalized for 4 weeks, resulting in a $700,000 hospital bill, how much will you owe the hospital? It's a very important question. Just for your information, I don't think I've ever met anyone with Medicare who has answered that question correctly. And I've asked retired doctors, retired hospital administrators. It's very curious. I almost never get the right answer on that, even though it's not a difficult question to answer. I mean, it's right there on Medicare's website. If you answered 20% of $700,000 or $140,000, you're way off. You're not even in the right ballpark. As I've said repeatedly, billing charges are works of fiction. Medicare does not use works of fiction to determine payments. What you actually owe for that $700,000 hospital bill is the Medicare Part A deductible, and only the Medicare Part A deductible. For any hospitalization lasting up to 60 days, a Medicare recipient only owes the hospital $1,408, which is the 2020 Medicare Part A deductible, not 1 penny more. Federal law prohibits any hospital from going after you for anything more than the Medicare Part A deductible for any hospitalization lasting up to 60 days. And you can see that right on Medicare's website. I got the link right there for you. All right. In other words, if your hospital bill exceeds $1 million, you owe the hospital $1,408. If your hospital bill exceeds $1 billion, you owe the hospital $1,408. If your hospital bill is 3 times the national debt, you still owe the hospital only $1,408. It's not 20% of anything. Okay. Now, obviously, that's a relative, and is 60 days enough? Well, the average length of a hospital stay in the US, even for Medicare patients, is only 5.5 days. We send open heart surgeries home in 5 to 6 days. We send liver transplants home in under a week. All right. 60 days is 11 times the average length of a hospital stay in this country. 60-day hospitalizations are about as rare as jackpot lottery winners. I'm not saying they never happen. They're really rare. All right. And here is an example. Now, the Medicare Part A deductible goes up about $30 a year, meaning 5 years ago, when this, for the date on this bill is 2015. 5 years ago, the Medicare Part A deductible was $148 less than it is now, $1,260. Here you can see this exactly what I'm talking about. Total charges on this bill, it was a 4-week hospitalization at Stanford, $711,000, right? And you can see, well, first of all, Medicare only agrees to pay $75,000, $74,958. You have $635,000 adjusted, completely disregarded, not paid by anyone to anyone. It's a work of fiction. And the amount due, the Medicare Part A deductible in 2015, $1,260. That's all you would ever owe if you have Medicare Part A and you're hospitalized, regardless of the billing charges. So this is easy to understand, and it's easy to look up. Yet, as I've said, I have yet to meet a senior who knew this before I told them about this. The vast majority of people who I ask will guess somewhere along the lines, if they guess anything at all, they'll guess 20% of the billing charges, which is obviously not even in the right ballpark. In the case of that bill, that's 100 times what they really owed. Okay, what about that 20%? The 20% coinsurance is for Part B benefits, but only based on Medicare's approved payment. And you really have to understand, Medicare approves about an average of 17 to 18% of billing charges in the United States. Now, that doesn't mean that Medicare's payment has anything to do with billing charges. It doesn't. It's just the average billing charge is about 6 times what Medicare actually approves for most medical services. And if you do a little math, the 20% you owe is only on the 17 to 18% that Medicare approves, which is actually about 3.5% of billing charges on average, which sounds like a lot less than most people think it is. All right? Bottom line, Medicare actually protects its recipients from medical overbilling far more than any private health insurance plan will. I wrote an entire chapter in my book on the many ways in which private health insurance companies deliberately throw people to the wolves financially by denying claims and leaving them on the hook for full costs. Medicare is the one program that, for the most part, doesn't do that. And yet, oddly enough, most of the seniors I've ever spoken to about this don't appear to know this. Now, two caveats. One, most preventive services and blood tests are covered by Medicare Part B for free, $0. All right. Mammogram, free. Screening colonoscopy, free. Most blood tests, free. No 20% of anything. However, in rural areas that are far away from population centers, there has been a policy in effect since the late 70s, unfortunately, that really does put seniors on the hook for 20% of full billing charges for certain services only in rural areas. The reason for this was in the late 70s, they wanted to attract more doctors to these areas. And at the time, billing charges averaged only about 15% more than what Medicare approved. Those were the days. Now billing charges are 500% on average more than Medicare's approved payments. So this really does leave seniors in rural areas sometimes on the hook for enormous medical bills. This policy needs to change. Obviously, it needs to be revisited. And unfortunately, like most of Medicare's policies, people aren't aware of this enough. But the vast majority of people, by definition, don't live in rural areas. They don't live far away from population centers. So this doesn't apply to the vast majority of Medicare recipients in the United States. Still, that policy needs to change because obviously people in rural areas are, if anything, less able to cover these enormous bills than, their urban counterparts. Okay. So if you're not in a rural area, just to give you some actual figures, the out-of-pocket expenses for, say, open heart surgery, start to finish, total, with Medicare, would be about $2,500. Here's a testimonial from one of my contacts. She actually put this up on the internet after reading one of my blogs about Medicare. Here she says, I did have a total knee replacement in 2012. While looking over the payments made, I found that Blue Shield paid a total of $1,100 from pre-tests to the last physical therapy and everything in between. So the entire total knee replacement, Blue Shield only paid $1,100. That was her Medigap policy. Medicare paid everything else, including the surgeon who billed Medicare $20,000 and was actually paid $858. Not unusual at all. So without her Medigap policy, she realizes she would have only owed $1,100 for everything on that total knee. Still, after presenting all of these to Medicare recipients I know, I often get this question. What if I have a catastrophic illness? Now, the word catastrophic obviously implies a lot of horrible things without any specifics. So I decided to add some specifics. And I took a patient of mine who had what I think you'll all agree is one of the most catastrophic medical issues you will ever encounter, or at least that I ever encountered. All right. So this was a patient of mine I diagnosed with liver cancer in December 2015. Yes, liver cancer. Over the next 2 years, she received chemoembolization. So her chemotherapy was directly injected radiologically into her liver, radiofrequency ablation, and a liver transplant. Yeah, liver transplant. In addition, she had 2 subsequent hospitalizations after the transplant due to a complication. She spent a total of 42 days in the hospital in 2017. Add to that all the outpatient tests, office visits, preoperative, postoperative care, including all the MRIs, ultrasounds, blood tests, you name it, etc. All the doctors, surgeons, everyone who saw her in the hospital when she was hospitalized, all of that. And I'll even add 61 sessions of psychotherapy and 16 sessions of physical therapy for issues unrelated to the cancer or the transplant. She brought me all of her bills for that entire 2 years. So this entire enormous conglomerate, I added up everything. Okay, all medical expenses. All right. So this all happened in 2016 to 2017. She's actually fully recovered now. Since the end of 2017, she's been fine, only a few follow-up visits and blood tests to monitor her new liver. But during those 2 years, she endured a total of 330 individually billable medical services, including the 3 hospitalizations. Is that catastrophic enough? All right. So the billing charges, how much did this cost? The billing charges, which are works of fiction, for all of this medical care did exceed $1 million. However, Medicare only approved about $180,000 in total payments for all 330 medical services, including the 3 hospitalizations. In other words, only $180,000 was paid to anyone, by anyone, for all of this medical care, which I think you'll agree is probably more than most people will ever need in a lifetime. So $180,000, 20% of that is $36,000. Does that mean that the co-insurance was $36,000? No, and this is important. All 3 hospitalizations were covered under a single deductible. In 2017, it was $1,316. Why? Because you don't owe a new deductible until your benefit period ends. And your benefit period doesn't end until you've been home for 60 days. In other words, they cover up to 60 days hospitalization, but before a new benefit period can start, you have to be home for 60 days. Well, she got her liver transplant in early July, goes home for about a week, gets a complication, gets hospitalized again for 4 weeks, goes home for about 6 weeks, which is not 60 days yet, gets hospitalized again in October for about a week. So she gets hospitalized for a total of 42 days between July 1st and the middle of October. And the total that would have been owed by this patient, for all 3 hospitalizations was the deductible, Medicare Part A deductible, $1,316 one time. And what's more, that would have covered 20 extra days in the nursing home at no extra charge as well. So more than $700,000 in hospital bills, $1,316 is all she would owe. All right. So the grand total in coinsurance and deductibles over the entire 2 years for all 330 medical services was $15,480. All right. That is a good amount of money, enough to buy what, a used Honda Civic? You have to admit, it's less than a tenth what most people would guess you would owe if you had Medicare and only Medicare for all of that medical care. And this is important because far too many people with Medicare assume that their bills with Medicare only would bankrupt them for a lot less medical care than this. They see that $400,000 hospital bill, they assume $80,000. They say, I can't afford that. But they're wrong. And this is the problem. Seniors really need to know how good their coverage is. Most of them don't understand it. All right. And the reason has a lot to do with these private insurance policies. So we'll start by discussing supplemental coverage or Medigap coverage. What is the cost of these plans and what actual benefits are provided to seniors for the Medigap policies? So first, cost. Almost none of the seniors I've ever asked who have Medigap policies are able to tell me exactly how much they pay. The reason for this is that most of the time when they sign up for these policies, they sign up for an automatic deduction of the premiums, either from their bank account or from their pension checks. And they long ago lost track of how much is paid. So I will ask them, could you go home and find out and tell me? And usually when they do this, they're rather shocked. And the reason they're rather shocked is that in most states, not every state, but in most states, the year after year after you turn 65, they start you off at one low rate, but then it's almost like a teeth. Oh, can you hear me? All right, sorry, I lost my connection there for a second. All right. they start you off at a low rate, but then those rates go up very quickly as you age. Here's an example. So this is from Blue Shield of California. They've gone down since then. In fact, I can assure you they haven't. All right. So first of all, you got 7 different plans to cover basically 2 deductibles and co-insurance. All right. Which of course adds to the confusion. I mean, that's one of the #1 techniques of insurance company. They like to confuse you so that they can rob you. But I have circled here. So if you're looking at the Plan F, all right, the fee for the Plan F when you're 65 to 66 years old. Now, the Plan F is the Cadillac one that covers all of your co-insurance and deductibles, so you end up paying nothing. And so it starts you out at $133 a month. But by the time you're 71 years old, if you can see that, the rates have gone up to $212 a month, which is a 60% increase. All right. And people lose track of that. That is a huge amount of inflation over 6 years. Now, $212 a month, that's $2,544 a year, which means by the time you're 71, you're paying enough in Medigap premiums, if you have this Plan F from Blue Shield, to cover an open heart surgery each and every year, 2 new knees each year. Remember, that woman had said only $1,100 was paid on her total knee. So that's 2 new knees each year, which is a great deal if you're a centipede. A new liver plus all the extras every 6 years for liver cancer. How many livers do you need? All right. As you can see, for what you get for these policies, they're rather pricey. Benefits. Medigap plans tend to cover only deductibles and co-insurance costs determined by Medicare. And this is rather important, okay? They don't cover uncovered expenses like long-term care unless you pay a lot extra. They wouldn't cover, like, if you ran out of lifetime benefits. There is such a thing with Medicare. It's pretty rare, but they wouldn't cover that either, okay? They only cover your $1,408 Part A deductible, your $190 Part B deductible, and your 20% co-insurance on Medicare-approved rates, okay? And what's more, they don't determine any of those payments. In other words, the administrative costs we often associate with insurance companies of determining what payments ought to be, determining what benefits ought to be, they don't do any of that. The entire purpose of a Medigap policy is that they write checks that you yourself could have written for amounts that are usually pretty trivial. And the minimum loss ratio on these plans, unlike the 80 to 85% minimum loss ratio that you often get with other health insurance, the minimum loss ratio for Medigap plans is 65% for individual plans and 75% for group plans. What does that mean? You go to the doctor and the office visit, Medicare says, well, that's worth $75. Medicare covers 80%, that's $60. Oops. Hello?
David, I'm sorry. Can you share your screen again?
Oh, sorry. I lost the whole thing. Let's see. Let's see if I can just go back into. Are you still there?
We hear you.
We
You
can,
can hear me, but I just
Right.
lost the.
I see you too. Oh,
yep, that was my mistake. Please,
How do I get back onto this?
You're on.
Oh, there it is. All right. It just disappeared. All right. So I share my screen again. Share. That's it. All right. Play. Okay. So the Medigap plan pays your 20% coinsurance, but that's all they do. They don't determine any payments. They have zero administrative costs whatsoever. So you go to the doctor, Medicare says that doctor's office visit is $75. Medicare pays $60, that's the 80%. You would normally just write a check for $15. not difficult to do. But instead, you pay the insurance company on an average loss ratio of 75%, meaning you pay the insurance company $20 so that they cover that $15 expense. You get an MRI. Medicare says that MRI is worth $600. That's all the provider's going to get. Medicare covers $480. They're 80%. Normally, you'd pay $120. That's your 20%. All right. But instead, you pay an insurance company $160 so that they can cut a check for $120 that you could have more easily paid yourself. You're paying a huge margin to an insurance company to do nothing but pay Medicare providers for Medicare approved services at Medicare rates. They do nothing to determine anything. Why do seniors meaning Medicare plan, with a 75% and with a 65% loss ratio, which you get with the individual plans, that's a 50% commission. You're paying for an insurance company to do nothing more than write checks you could have written yourself more easily. Why are they so popular? Well, I hear it over and over again. Hey, look, last year I was hospitalized for a heart attack, ran up a $300,000 hospital bill. I didn't know anything. They have no idea how inexpensive their health care would be with Medicare alone. Far too many seniors, the majority of them, believe that Medicare alone would leave them bankrupt for relatively trivial health care costs. And they need to stop believing that. All right? Because right now, Medicare does all of the work, pays almost the entire bill, and is getting almost none of the credit. And I hope you're seeing how these policies are undermining Medicare. In fact, I hope you're seeing how these policies are undermining everything you're trying to accomplish. Because if people believe that Medicare easily leaves them potentially bankrupt for relatively trivial medical costs, which it doesn't, then you can see why a lot of seniors would be at best lukewarm about the Medicare they have. Well, okay, it's a good plan, it's a nice plan, but it's inadequate. In the minds of all of these seniors, it's phenomenally inadequate because they have no idea how good Medicare is because these private insurance plans are hiding that from them. And I know this from talking to seniors all over the place. They assume that Plan F at $200 a month is a good deal, when in fact, unless they're getting open heart surgery every single year, it's probably not. All right? Now, Medicare Advantage, another one of the plans. Well, it takes advantage of seniors. I mean, come on, it's in the name. The purpose of Medicare Advantage is to funnel Medicare money, CMS money, through the private insurance companies so that they can keep a cut. All right? It's basically a way of infiltrating Medicare. Medicare, as it is run, embarrasses the insurance companies. It doesn't compete with them. It embarrasses them for what it offers and the price that it does. But if the insurance companies can tap into that seemingly endless supply of federal money, well, they're perfectly happy with Medicare as long as they can manage it in their own way. And what is their own way? Well, they bottleneck healthcare services. They add massive amounts of confusion. I mean, the number of Medicare Advantage plans that you can get in any different state, all the different co-pays that you have. I mean, you saw how simple Medicare was. A Part A deductible, a Part B deductible, a 20% coinsurance. Well, you have dozens of different Medicare Advantage plans offering dozens of different services in dozens of different ways, and of course, networks. Okay? I mean, what's the purpose of a network, right? Insurance companies originally set up networks so that they could get a discount from various providers who are willing to trade a little extra money on their fees with a large volume that the insurance company would send them. Well, with Medicare Advantage, the providers are treating Medicare patients for Medicare approved fees, for Medicare approved services. What is the point in having a network? It doesn't offer anything other than confusion and the risk of seeing a out-of-network provider or being taken to an out-of-network hospital if you happen to be in a coma and paying a lot more. So the networks by Medicare Advantage offer no advantage to anyone, only the risk of increasing your costs and the confusion. And of course, you have all the unnecessary authorizations because God knows we don't want people getting too many colonoscopies because they enjoy it, right? So they increase confusion, increase costs, bottleneck services. Well, what's not to love, right? However, they do offer prescription drug benefits and sometimes gym memberships. And while we're on the topic of prescription drug benefits, let's talk about Part D plans. Okay, so Part D plans offer prescription drug benefits. And it is the one private Medicare policy that seniors sometimes need. And I do stress sometimes. So before we discuss that, we need to talk about the Part D penalty. Seniors are often warned by these insurance agents of that horrible penalty. They never tell you how much because the word horrible scares you and the actual amount wouldn't. It's 1% of what's called the national base beneficiary premium or average premium cost each month you delay. That amounts to a horrible $3.74 per month each year you delay. That's right, less than $4 a month extra every year you delay. So if you delay 100 years, it's $374 a month. In other words, it's something most people could afford. Can you hear me? Oh, okay, great. My internet went out a little bit. Okay, so the penalty is not horrible. The price, again, they add a lot of confusion. You have multiple, in most states, you have multiple different Part D plans offered by several insurance companies, all right? And the price range can be anywhere from $10 a month for plans that virtually cover nothing to over $100 a month for plans that do cover a lot, but they're quite expensive for what you're getting, all right? The benefits. I can tell you right now, the vast majority of Part D plans will give you no help whatsoever with any generic medications. Unless it's a Cadillac plan, you will get absolutely no help, which you wouldn't notice. Medications don't cost anything, right? So, for example, let's go back to my liver transplant patient. As you can imagine, a liver transplant patient would need a lot of medications. She needed over 24 prescriptions. She had a plan called Silver Script, cost her $28.50 a month. All right. However, all of the prescriptions she received, all 24 prescriptions she received, were for generic medications. I see this a lot now. All right. And what's more, her anti-rejection pills, which are generic and not that expensive, they were actually covered by her Part B benefits. She didn't even need an extra Part D plan for her anti-rejection medications. However, how much she paid for all of her medications that year in copays, how much her insurance contributed, how much her insurance paid for each of the medications she bought, and how much the pharmacy paid for each medication she bought the month that she bought it. All right. Now, her insurance, on average, paid less than half as much as she did for 21 of her medications. In fact, they paid exactly nothing for 8 of them. Her insurance paid a total of $110 for those medications, whereas she paid more than $250 in copays, and these were medications that the pharmacy got for only $212, meaning she paid more than twice as much as her insurance company did, and her copays more than covered the cost of the medication to the pharmacy. Add to that the $340 she paid in premiums. She didn't get a really good deal on those medications, but she did have one very expensive medication. Because she was a liver transplant patient, most transplant patients are prescribed a medication called valganciclovir, generic Velsite. Even though it's generic, it's still rather pricey. And the reason that it's rather pricey is that the brand name version is more than $80 a pill. And it had only become generic in recent years, which means, well, so she comes to my office in September. telling me, well, there's one medication that I don't get much help with. I pay a $1,200 copay. That's what she told me. $1,200 a month she was paying for her generic valganciclovir. All right? Just that one medication. Everything else was cheap because the medication didn't cost very much. All right? So how much did it cost without insurance? Well, I spend about a minute going online looking up the lowest cash price, and I get this coupon. This medication that she was paying $1,200 a month for with her insurance, she could have purchased at Costco for $844 a month. In other words, her savings without insurance would have been $350. They gave her, not only did they give her absolutely no help, as I've said often, they actually made it harder on her, which is not unusual. As far as Part D plans are concerned, they're run by pharmacy benefit managers. No rebates equals no help. There are no rebates paid on any generic medication, including expensive generic medications. Since there are no rebates, PBMs have absolutely no motivation to help you purchase them. So if it's cheap, they'll let you buy it for maybe a little bit more than it costs. If it's expensive, you're on your own. Okay. However, they do help seniors purchase brand name medications. Sometimes. Sort of. Here's the problem. If you're not currently taking a brand name medication and you purchase a Part D plan with the assumption that you might need a brand name medication in the future, there's no guarantee that the plan you bought that you're paying for now is going to actually cover the brand name medication you need in the future, because all of the formularies are relatively incomplete. Meaning you might buy a plan, pay all that money in premiums for it that isn't helping you at all, and then suddenly the doctor gives you Eliquis and you find that Eliquis is tier 3 or tier 4 or whatever, and if it's covered, it might be over $1,000 a year or even $2,000 a year in your copays and deductibles. Great. All right. So it's a little like, I like to use the analogy, when you're buying a Part D plan, because the coverage for brand name is so incomplete. And the generic medication prices are so low, seniors assume that their insurance is giving them help, which it's not. Meaning the vast majority of medications they're purchasing, they're not getting any help with it at all. And the brand name coverage is so incomplete. It's a little like buying a homeowner's policy that covers fire insurance, but only if the fire starts in a certain room or at a certain time of day. Okay, this is the kind of coverage you get with Part D plans. All right, and what's more, the pharmacy benefit managers who are running these Part D plans are primarily responsible for this runaway inflation in brand name medication prices. In other words, when you purchase a Part D plan, they allow you to benefit from their 40% rebates. So you get a discount, plus they get federal money to help them purchase it. But the fact of the matter is, it's the rebates that have been encouraging the runaway inflation of these brand name medications. So the end effect of the Part D plans is that they've made medications overall far less affordable for seniors. So really what I always tell people, your best option with a Part D plan, postpone buying it if you're not on a brand name medication. If you're given a brand name medication, that's when you sign up for a Part D plan and pay the fine. You will probably save money in the long run if you do it that way, because when you are prescribed a brand name medication, you can go online and see what your copay, your deductible, and your premiums will be, and you can find the plan that covers that brand name medication for the lowest combined price of copay, deductibles, and premiums. If you don't do that, odds are you will end up paying far more for that brand name medication otherwise. It's not a good deal, but it's probably the best deal you could actually get, because these plans are so confusing, so convoluted, and basically so corrupt. All right, so the summary is, all three of these private plans with Medicare, for Medicare recipients, increase both costs and confusion for those who have them, and provide very little actual benefit. In fact, my advice is always, Go with a Part D plan if you're on a brand name medication. Otherwise, all you need is Medicare Part A and Medicare Part D. And this is what seniors need to know. Because my conclusion for this whole thing, if you wish to accomplish anything in reforming healthcare, the first thing you must do is take back Medicare for seniors who have it. Seniors need to know not just that they have the best deal in the United States for their health care, they need to know why. They need to know how much they really owe on those hospital bills. Because right now, the private insurance companies send out financial advisors to all these senior centers and all these seniors organizations with half-truths and warnings and talk about horrible, horrible consequences in bankruptcy if you're not, buying all these private plans. It isn't just that they're making a huge amount of money off of these plans. They are. It's that these plans infiltrate and undermine Medicare directly. And by undermining Medicare directly, they're undermining everything you're trying to do.